In this video, we'll discuss superiority and non-inferiority testing in clinical trials. So really the difference between the two is that with superiority testing, our goal is to determine whether one treatment is significantly better or significantly worse than another. It's like a race. We're trying to pick what is the best one. But with non-inferiority testing, our question is actually, is one treatment not meaningfully worse or just as good as another treatment? And the way that we design our trials between the two is actually different. As an example of superiority testing, the CRASH-2 trial was a study conducted in about 20,000 patients who had significant bleeding due to trauma. And those patients were randomized to tranexamic acid, TXA, or placebo. And the goal of the trial was to determine whether TXA was significantly better than placebo. So in this case, the null hypothesis was that TXA does not reduce mortality in trauma patients, so mortality was the endpoint. And again, the null hypothesis is that nothing is different, no change, no benefit. The alternative hypothesis for the CRASH-2 trial was that TXA does reduce mortality in trauma patients, and we would accept the alternative hypothesis or reject the null hypothesis if our p-value is small. So a significant p-value, typically less than 0.05, would indicate that one treatment is superior or better to the other treatment. We can actually visualize superiority in the CRASH-2 trial. So in this graphic, this is the whisker plot of the confidence interval of the relative risk of TXA versus placebo. So you can see here at 1.0, that would indicate no difference between tranexamic acid and placebo. If the relative risk is smaller, that means that tranexamic acid is better. If the relative risk is bigger than 1, that means that tranexamic acid is worse or placebo is better. So when we analyze a relative risk in a confidence interval for superiority testing, our question is really, does the entire 95% confidence interval only include values that are less than 1 or only include values greater than 1? Or in other words, do we cross 1.0? So as long as all our values don't include 1.0, we would conclude superiority for one therapy or the other therapy. Now, when we analyze the patient population for superiority, we use a principle called intention to treat, or ITT. A term for this is also once randomized, always analyzed. What that means is that once a patient is randomized, let's say to treatment or placebo, and let's say we had 100 patients per arm, and during that trial period, we might lose some patients to follow-up. So in this example, we lose 10% of our patients to follow-up. And then over time, maybe some of our patients don't do what we told them to do. So maybe 20 patients in one arm stopped taking our treatment, and 5 patients in the other arm stopped taking our treatment. At the end of the day, though, when we actually analyze our data using intention to treat, we will include all 100 patients. Even if they were lost to follow-up or stopped therapy, we include all 100 as part of our intention to treat study design. So why would we include all 100 patients per arm if some patients dropped out or didn't do what we asked them to do in terms of taking our drug therapy? Well, the first reason is that this is what happens in real life. So in real life, not everyone is going to take our therapy. For that reason, we want to get a real life representation of the benefit or lack of benefit of our drug therapy. The other reason is that this produces a higher bar for the study to actually prove superiority. It accounts for a bias in the study design in terms of patients being non-adherent, or especially if they're poorly tolerant to the therapy. And the reason for that is that as patients stop doing what we tell them to do, and they become non-adherent or lost to follow-up, our p-value will go up. It'll be harder for our study to show that our treatment is beneficial. Now, the alternative to a superiority study design is a non-inferiority study design. So as an example, the REDUCE trial looked at about 100 patients who were hospitalized with a COPD exacerbation, and they randomized patients to get prednisone 40 milligrams for 5 days or 40 milligrams for 14 days. So in this example, the null hypothesis of a non-inferiority trial is the opposite of a superiority trial. So in this case, the null hypothesis is that a 5-day course is inferior or meaningfully worse compared to a 14-day course. And again, this is the opposite of superiority. Our alternative hypothesis is that a 5-day course is not inferior or not meaningfully worse compared to a 14-day course. Now, the interpretation of the p-value is the same though. So if we have a significant p-value less than 0.05, we reject the null and accept the alternative hypothesis. So with a significant p-value, it proves non-inferiority for this trial design. Now, for non-inferiority trials, they have to come up with what's called a non-inferiority margin. And this is a margin that determines how different we allow a treatment to be, but still be considered non-inferior. So as an example, our non-inferiority threshold might be about 1.3 for a trial. What that means is that we don't want our confidence interval to include anything that is to the right of that non-inferiority threshold. So if any part of our 95% confidence interval exists in that space, that would include scenarios in which our therapy is meaningfully worse than whatever we're comparing it to. So for example, if our confidence interval is far to the left, we're happy with that. That would mean that we've proven that it is not meaningfully worse. Even if we cross 1.0, for non-inferiority trials, that doesn't matter crossing 1.0. We're only concerned with the non-inferiority margin. Even if we're very close to the right of 1.0, but we haven't exceeded the non-inferiority margin, we would still prove non-inferiority. It's only once we include a component of our 95% confidence interval, so in this case, because we now have crossed that margin and our confidence interval includes scenarios that would be meaningfully worse based on whatever that criteria is, that then would fail to prove non-inferiority. Then of course, if our entire confidence interval is in that category, we would fail to prove non-inferiority. So in the reduced trial, we can actually visualize this using a whisker plot. So again, we have the 95% confidence interval of the hazard ratio. And for a non-inferiority trial, we actually don't care about crossing 1.0. For superiority, that's the interval that we would use to determine statistical significance or not. But in this case, we're only concerned with the non-inferiority margin. And we're asking whether our upper bounds, the highest value of our 95% confidence interval, is below the non-inferiority threshold. So in this case, for the reduced trial, the threshold was 1.515, and the authors have to justify how they pick that non-inferiority threshold. It could be based on FDA criteria or based on expert opinion. And for the reduced trial, the highest value was 1.26. And 1.26 is represented as the upper bounds of our confidence interval. That's really far away from our area of non-inferiority. So this would mean that we've proven non-inferiority in our trial because our worst value in our confidence interval is still lower than 1.515, our non-inferiority margin. So based on that, because we're less than 1.515, the reduced trial concluded that a short course, 5 days of prednisone, is non-inferior to the standard course, 14 days of prednisone. We discussed that superiority studies use an intention to treat trial design. This is different with non-inferiority trials. They use what's called a per protocol analysis or an as treated analysis. So using our example again of randomization to 100 patients in treatment, 100 patients in placebo, and we have patients that are lost to follow-up and patients that stop taking our treatment, at the end of the day, we had 100 patients in each group for our intention to treat, once randomized, always analyzed. But for our per protocol, we only are going to look at patients that were not lost to follow-up, that did continue taking the therapy that we asked them to do. So in the top case here, we had 100 patients, but 30 of them stopped doing what we told them to do. So we will not include those 30 patients in our per protocol analysis. Similarly, for our placebo arm, we had 15 patients that either were lost to follow-up or stopped taking treatment. We will not include those patients in our per protocol analysis. Why would we use per protocol as a trial design for non-inferiority studies? It's probably best explained using a slippery slope argument. So let's say that we had our trial again with 100 patients in treatment and 100 patients in placebo. Let's say placebo, no one stopped taking our therapy, and we had 100 people there. For our treatment though, maybe it was a very intolerable therapy, and almost everyone, 90% of patients, did not take our therapy. So we have 10 patients that did what we told them to do, and 90 patients stopped taking our therapy. What's going to happen then is that when we analyze our data, our treatment group is going to look really, really similar to our placebo group because effectively our independent variable is not different. We intended to have an independent variable of treatment versus placebo, but too many people in the treatment arm were similar to placebo arm because they didn't take our therapy. So because of the similarities in treatment between the groups, it would be very easy to show non-inferiority if we used an intention to treat study design. So for that reason, for non-inferiority trial design, we prefer a per protocol analysis because it captures this bias of patients potentially not taking the treatment that we assigned to them. For our self-assessment, which of the following hazard ratios with 95% confidence intervals would demonstrate non-inferiority with a non-inferiority margin of 1.66? Is it 0.66 with a range of 0.42 to 2.44? Is it 0.74 with a range of 0.66 to 0.99? Is it 1.29 with a range of 1.01 to 1.99? Or is it 2.65 with a range of 1.54 to 3.57? Pause the video and think about which of these would demonstrate non-inferiority with a margin of 1.66. The correct answer here is going to be 0.74 with a range of 0.66 to 0.99. And the reason for that is that our non-inferiority margin is 1.66. So that means that our confidence interval cannot include any values of 1.66 or higher. So this is higher than 1.66, this is higher than 1.66, and this is higher than 1.66. In this case, our worst value is 0.99, which is below our non-inferiority margin, which would allow us to prove non-inferiority with that 95% confidence interval. For our second self-assessment, which patient population is most appropriate for a null hypothesis of lisinopril does not reduce mortality in heart failure versus placebo? Is it as treated, intention to treat, or per protocol? So in this example, this is a superiority analysis. We're analyzing whether lisinopril reduces mortality or not with placebo. So with a superiority analysis, we prefer an intention to treat patient population. As treated is a synonym for per protocol. That would be more appropriate if we have a non-inferiority trial design. Thanks for watching. This video is actually one of 35 videos from ClinCalc Academy's Biostatistics RX online course. If you're interested in developing a rock-solid foundational understanding of biostatistics and medical literature evaluation, check out a link in the show notes, which includes access to the 35 videos, which is about 5 to 6 hours of content, more than 100 comprehensive quiz or exam questions, and even access to a free 10-question exam on biostatistics. Again, link is in the show notes, and thanks for watching.